One.
I'd like to once again thank the organizers for allowing me to give this talk about epilepsy diagnosis and seizure semiology, an extremely important topic. I have no conflicts of interest. And today we're going to be discussing seizures versus non-epilepsy paroxysms, pairing childhood epilepsy syndromes and constellations with the correct anti-epileptic medications, and what happens if medications do not work. I'm going to be initially discussing a case of that of a 7-month-old right-handed female. Immediately, a flash, right-handed, presents at 5 months of age with a diagnosis of a neurocutaneous syndrome, epidermal nevus syndrome, sometimes but not always associated with an overgrowth phenomenon. At about 4.5 months, she started having these clusters of extension and flexion of her upper extremities, and the EEG revealed what was described as a hypsarrhythmic pattern. So quite interesting, elevation of both initially, but two things that you notice immediately. She's moving the right hemibody more than the left. And when she has the extension, she extends one a bit more than the right. So that suggests that it's not really a generalized process per se. The spasms are, but maybe focal. She was developing normally until the event started, then she began having some regression. Medications tried, steroids, you may say why, but we'll find out pertaining to the syndrome. Vigabatrin similarly, and lacosamide, none of which were effective long-term. So the questions we ask when we see these paroxysms, does he, she have epilepsy? Does he, she have a defined epilepsy syndrome? What is the evidence for effective treatment in such an epilepsy syndrome or seizure type? Why is it important? 70 million persons with epilepsy around the world, 500 million persons affected, whether it be families or others. Approximately 80% of those individuals live in poorly resourced settings, such as the region where I'm from, the Caribbean, and approximately 2.2 to 3 million persons in the US, where I'm presently practicing. But first, we have to backtrack a bit and define what a seizure is. This goes way back, 6th century BC, when Atreus suggested, the father of Indian medicine, paroxysmal loss of consciousness due to disturbance of memory, understanding of the mind with a convulsive seizure. And Constantine, the African, also stated the same thing suggested by the Greeks. How about his neck turns left, his hands and feet are tense, his eyes wide open, from his mouth throat is flowing without any consciousness. That's even way back when, Mesopotamia. So the initial one seems like a more diffuse process or generalized, whereas the other one, head and neck turning left to one side, may suggest something coming from the contralateral side. How about Hippocrates, much later? If he foams at the mouth and kicks, Ares has the blame. When at night occurs fear and terror jumping from the bed, they say Hecate is attacking. Out of this world phenomena they're describing. And how about atypical events that you're not sure if they're seizures or not? Dostoevsky described grateful for his seizures, abnormal tension, allowing him to experience unbounded joy and rapture, ecstasy and devotion and completeness in life. And just from the history alone, we can determine semiology, the first one likely coming from the frontal lobe and the second one possibly the temporal lobe. So a seizure is that creation of that imbalance. So you have excitation on one hand and you have inhibition. If you strike that balance in the brain, you're okay. If that balance tilts a bit, the circuitry of the brain gets excited, and the aberrant circuitry disrupts the normal circuits. If that aberrant circuitry disrupts the circuit for motor, then you may have stiffening or jerking. If it disrupts the circuit for smell, you may have an intense atypical smell. If it disrupts the circuit for taste, your taste may be funny, and that is a seizure. So not all seizures are generalized. They may be very atypical. But then how do you classify it? Initially, Hewlings-Jackson suggested that you should classify localization onset or local onset. And Gusteau said, you know, we need a much more detailed classification. So how about simple partial in 89, complex partial, and generalized, which we used for years. Simple partial being a focal seizure without altered consciousness, complex partial being a more complex seizure with altered consciousness, and you could have secondarily generalized seizures. How about the generalized seizure type, primary generalized? Now these terms, although we have used them, are somewhat atypical. What exactly does partial mean? Is it half a seizure? Is it a seizure that did not evolve? And complex, how do you tell a complex partial seizure in a 6-month-old? Or primary generalized, is that really primary generalized? Are you suggesting it's genetic, not genetic? So there were some complexities that were concerning. Even the syndromes, cryptogenic. What does cryptogenic mean? We think it's symptomatic, but we're not sure. So a number of folks got together in the International League and said, you know, partial or localization suggests that it's coming from one area, which means focal. And they can either have impaired, not impaired awareness, or we just don't know. And pending where it comes from and what it does, then you can describe it. So they came up with this new nomenclature, focal aware seizures, meaning focal seizures, one side, aware, you're fully aware, focal impaired awareness, and focal that spreads to bilateral, which make a lot of sense. Hence the new classification of seizures, focal aware, impaired aware, then you can descriptively determine what they do. Atonic, drop, loss of tone, clonic, rhythmic jerking, myoclonic, rapid, lightning-like jerking, and the various forms of behavior, picking or automatisms, an atypical sensation with awareness and aura. So you then can break down the various seizure types. But it's not always that simple. Sometimes it can start in one place and spread so quickly that it looks diffuse, and you act diffuse. So before you can even sense that smell, you're immediately stiffening, tonic-clonic. Hence the EEG, done with a nomenclature that could be understood anywhere. Odd numbers are right, even numbers are left. F frontal, frontal pole, frontal, central, parietal, occipital, temporal. So if someone says there's a discharge from T3, odd number left, T temporal is left temporal. Or it may be generalized, as in these waveforms, all over, a generalized 3 Hertz spike and wave. Before even seeing the patient, I can tell you this patient likely has absence seizures. Or with focal seizures where these discharges meet, C3, this is a central left, so left central focal seizure. So that's exactly what we did in our patient. But it didn't meet any of the criteria. It doesn't look at all like the EEG here. It was very chaotic, discharges all over, huge amplitude discharges with what we call attenuation or flattening of the EEG. This is characterized as hypsarrhythmia. And hypsarrhythmia, with the patient's age and the seizure type, that patient has spasms or infantile spasms. Steroids is one of the mainstays, along with ACTH and or vigabatrin. And in treating with steroids, it was not only therapeutic, but helped with diagnosis. You see that focal discharge predominantly coming from the right, which now makes sense. The kid was moving the left side more, and in between seizures had normal movement of the right side. So we now know we have this cute little kid that's having focal or hemispasms as well as more bihemispheric spasms. We know likely where they're coming from the right. So the next thing is to do an MRI, which may show you a gross abnormality, somewhat blurred abnormality, cortical dysplasia, or even more subtle. So we did one in our child. And it was suggested to be normal. But if you take a closer look at the area in question, that area being the right side, you can see that it looks a lot fuller than the other side. So this area is abnormal, but because of age, we can't tell definitively if it's diffuse. So it may be hemimegalencephaly, the whole hemisphere, or it may be just a partial. So we now have someone that have had a cluster of seizures. What's the probability of going on to having other seizure types? We know that within 2 years, if you've had one seizure, the probability is by about 40 to 50%, you're going to go on to have more seizures. But if you have 2 seizures, it goes up incrementally to about 73%. And that is why the International League has suggested that if you have at least 2 unprovoked seizures, you likely will have epilepsy. Now, they have changed the characteristics a little bit in that if you have 1 unprovoked seizure and the EEG suggests that you may have more than 1 seizure within the next 10 years, you can coin it epilepsy. Or you could diagnose an epilepsy syndrome if you know what the characteristics are. You could also not have epilepsy if you go without it for 10 years and we take you off medications for 5. But knowing the seizures is not enough. You want to better characterize that epilepsy syndrome based on seizure type, age, EEG, whether that EEG is focal or more generalized. An MRI, as alluded to, would help. And then your neurocognitive status. Are you normal? Are you not normal? Are you regressing? And then they have other variables. So you go through the same thing that you tend to go through in other aspects of medicine. You history, look at the patient in totality, then you do EEG and imaging, and now coming up really quickly is genetic testing. And from that, you see the nice flow diagram and paradigm here by the International League Against Epilepsy, showing that cumulatively putting everything together, you can come up and try and determine etiology. The question often is, I tend to go to 3 islands during the year and give service, mainly seeing patients. And in some, they suggest we don't have EEGs, what do you do? A colleague of mine, Roxanne Chambers, myself and others came up with this questionnaire. They have another one in Ecuador. That's a very helpful screener, although it doesn't say everything in totality. Because the reason you want to do all this, we have many medications in our arsenal. The mainstay in most places being valproic acid, carbamazepine, phenobarbital, less so dilantin, but a lot of other medications have come on board with less side effects and sometimes equal efficacy, not necessarily proven yet to be more efficacious than most. And it totally depends on the syndrome type and seizure type, because you can do harm. If you give some people carbamazepine that have generalized seizure types, it could potentially get worse, etc. How do they choose? The way we often choose medications: randomized clinical trials, see what the efficacy is versus effectiveness of the medication, level of evidence, your national drug formulary, of course, expert consensus. And in pediatrics, we have to make sure we do no harm, but that people can take the medicine. So it don't make sense giving a child a tablet if they can't swallow a tablet, or a medication that's going to taste yucky that they're going to spit out. So you have to actually try and figure out how best to get the medication to the child. So going back to the whole milieu of trying to define a syndrome, this is another kid, 4.5 weeks old, was alert for 2 weeks, now encephalopathic. EEG shows a burst suppression pattern, and that's not as important as looking at age, EEG, seizure type, flexotonic, flexospasms, and coming up with a diagnosis. Early infantile epileptic encephalopathy. From that, you can determine its Ohtahara's. The kid had a disconnection of the abnormal hemisphere that you can see here, and several years later, this is 2.5 years later, you can see that 6-week-old child that could not move is now not only moving, but has pretty decent expressive and receptive speech. And even that weak hand that he has, he can actually clap and open his hand. So that's why we do what we do. So the issue is, if you have tried a few medications and the medications just don't work, likely if you have tried 2 to 3 medicines and they don't work, 30 to 40% of individuals are very resistant to agents. Some people push that to 20% because retrying other novel new meds sometimes help a bit. So what do you do in that case? This is a paradigm we can discuss after, but after failure, you want to do prolonged EEGs and other investigative studies. These are terms that we can address in the questioning: positive emission tomography or PET scan, single photon emission computer tomography or SPECT scan. These help with localization of the seizure. A magnetoencephalography help with localization, but also can assess function and functional MRI. Because you want to determine function versus seizure freedom, because you have to balance both in moving forward. So that's what we did in our case. We determined in our case via MEG and PET that the patient had an abnormality there. We determined a lower left where the abnormality is and where function was, and we did a disconnection of the hemisphere. And left that frontal area with motor. So it was a motor-sparing temporal-occipital resection, seizure-free now for 13 months, and is doing very well and has some mobility. So I hope I showed you the flow with which we go through with a patient to better diagnose the patient and improve management. But you have to look at the patient in totality. So it's not only the patient, but the family, education, educate the teachers. We do research with this, clinical care, and it's a branching tree as you go. And then back to basics. I showed you all these fancy tests, but history. Observe closely. Tests are done to support your hypothesis. Determine the syndrome, and then and only then do we treat with anti-epileptic medications. So I know this was quite a bit to take. I'm open to questions, and I'd just like to thank you. This is the Healing Garden from the hospital where I work, Dell Children's. But I'm very appreciative, and hopefully I can be there in person next time. Thank you.